So I think we can just jump right in here. And I wanted to ask, thank you so much for all your wonderful talks. And if you could each take just a couple minutes to tell us whether you think we're taking the right approach, or do we have the right conceptual framework? Are we asking the right questions and designing appropriately our studies so that they can guide clinical practice and public health interventions? And then if you could speak to how your work has been translated to various stakeholder groups to allow them to make decisions, that would be great too. So do we want to start? Who wants to start?
Okay, great. Yeah, those are excellent questions. And I think we can always do better, and we can always ask better questions. And that's the piece that I think I struggle with a little bit, right? How do you crystallize a question in maybe a reductionist perspective? Because a lot of what we do is about simplifying our experimental models, or simplifying our study designs such that we can control for a lot of these confounding factors. So how do you kind of come from that really powerful approach, but consider the systems that we're working in are nonlinear, and consider that the systems that we're working in can have emergent behaviors and can have a lot of, pieces where you tug on one thread and you find it hitched to everything in the universe, as we heard this morning. So I think it's there that we don't have really good designs. We don't have really good methodology to take a systems approach to studying some of these problems, but we've got great reductionist things. We can think in a causal framework. So I've been doing a lot of thinking around how you design One Health studies, because they are intrinsically multidisciplinary. They sort of intrinsically pull from this systems thinking perspective, and kind of a good first step is trying to harmonize our data collection. So with Laura Kahn and a number of other really wonderful people, we have some guidelines for the design and reporting of One Health epi-studies. It's called COHERE. And that's maybe a step for certain kinds of studies, but it's not a panacea. It's not going to be the solution for everything. And it's a process. It's a process of trying to capture all the data so that when we maybe make improvements to the way we think about things, that we can come back to the data we've already collected and pull new findings and new perspectives out of it. So that's just where I've been coming from.
Okay, so I agree that cross-disciplinary or transdisciplinary work is really the right way to try and synthesize the different silos of work that we're doing. I try as much as I can to look in these very small mechanistic studies and then expand up or back down as possible. I really like mixtures studies, and where we're starting to be able to go with that, with increased modeling and the access to big data sets. I think those are very powerful tools and can help us get more rapidly at what's happening, the interaction or interface between these environmental exposures and infectious disease in all sorts of different organisms and ecosystems in particular. And where we've started going, that I didn't get a chance to talk about, was thinking even farther out afield and outside the box. So we're starting to think about food webs and interactions amongst infectious disease and environmental toxicants, from phytoplankton to copepods and eventually up to fish and people, right? So it's a very aquatic, I'm on the Eastern Shore. There's a lot of water there. So we're starting to think about that. But so being able to tie in many, many more different fields of studies, the chemists and the engineers, as well as the toxicologists and immunologists and epidemiologists, gives you a much broader perspective and adds that secret sauce, I think, to making things more interesting.
Great. Mallory.
Yeah, so I'll kind of just touch on a few of those things and maybe add a few more. I think one of the challenges that we have, particularly looking at pollutants and their effects on the immune system and also clinical disease, is that we need more cross-training in the sciences. Whenever I talk to an immunologist or a microbiologist or a pediatrician, everybody's like, oh, yeah, it's important, but you need everybody to be working together to design a study that is as strong as possible that all disciplines are going to believe. And so I think we need more environmental health, as the environmental health person, in medical school training and in microbiology and in immunology. We can't live in these academic silos anymore and expect to address new emerging questions. So that's the plug for transdisciplinary education. And it's the plug for our public institutions and really trying to strengthen the educational systems that we have. I think there's a saying that a U.S. medical doctor maybe gets 30 minutes of environmental health education total in their entire MD career. So really the only pollutant that they believe has any effect is lead. The rest of the work that we're doing just doesn't really resonate. So if it's not perceived to be important, it's not going to be investigated. So I think that's something that's very tangible and something that we can do starting now, and some of us have been working on that for a long time. The other thing is the surveillance systems that we're using need to evolve to address emerging issues. And also the funding that goes along with that. I think we've all experienced grant review panels where these types of interdisciplinary ideas have just bombed because things are getting reviewed in silo. So either we need specific RFAs that are looking at these kind of interdisciplinary challenges, or again, that education, but it goes again to the policy piece, which also includes the funding and the research support agencies. The earlier question that we had as well to the first panel, which was around communication, I forget who asked that, but that was excellent. I think there is enough data out there now to start communicating this. I would agree that scientists, we do a terrible job of it, so I think we need to partner more with people that do a good job of it. And we shouldn't be afraid to do science-based education/advocacy as professionals in the field. So I'll stop with those three.
Great. Dr. Granum, do you have any thoughts for us from Norway?
I believe that most of my thoughts have already been shared by the others. But I really agree that interdisciplinary research is important, but what we struggle with in Norway, at least, is funding. Because this kind of research is expensive and it takes a lot of effort. I don't know how the funding situation is in the US, but that is a problem here. We have recently finalized some exposome projects. It was 3 exposome projects that was funded by EU, and there is no new call. And the experience is that these projects has to be pretty large to cover all the disciplines that they should include. But I believe that there are some exciting results coming from those studies now. So I would like to go on in that direction and have multiple exposures. I believe that is important and go away from one exposure, one health outcome. Okay.
Thank you. And then can I ask you another question? Are we asking the right endpoints? Are we using the right endpoints in our studies? Or what should we be using both in the human and toxicological research studies? Do you have any thoughts on that you want to share?
Are you asking me?
Yes.
Yeah. Okay. When it comes to toxicity, we have the four arms that I mentioned: hypersensitivity, autoimmunity, immune suppression, and immune stimulation. And I believe that those 4 arms covers well the outcomes. However, there is a lack of guideline studies for these outcomes. As far as I know, we only have guideline studies for antibody production in the one generation extended one generation toxicity testing, and we have one for skin sensitization. So yes, I believe that we have the outcomes, but we need good methods to actually analyze them in a standardized way.
Does anyone else on the panel have thoughts on that?
Well, I think the outcomes that we have are really good in those 4 domains. I think that actually kind of captures a lot of territory. I want to make a plug, though, again, that we need equally good exposure assessment. So often it's easier to measure the clinical outcome or subclinical outcome than it is to put together an exposure history on people that actually reflects what they've been exposed to at different periods of time. So again, especially when you see a lot of investment in cohort building, the children's health studies being an ECHO being an example, there's a lot of talk about the health outcome. There needs to be an equal amount of exposure, talk and discussion around the exposure assessment so that those two can blend in together and actually make sense. It's almost impossible to go back and retrospectively make a good exposure assessment. So again, I'd like to really see a real merging and melding of exposure science with health science in order to really make sure that we are asking, or I think we're asking the right questions. I want to make sure we have the right data to give the right answer to the question.
Great. Well, I want to be able to open up the questions to the audience here. So should we start to the right?
Hi, Lisa Aylward from Summit Toxicology and University of Queensland. Thank you very much for all of your talks. I'm wondering if I think we're seeing, very interesting human data, which is wonderful, using biomarkers at different time points of potential susceptibility. And we're looking at we've looked at a variety of different compounds. I'm struck by the fact that we're seeing, for instance, with respect to vaccine titer, adverse effects on, or associations with a variety of different compounds. We've talked about methylmercury or mercury. We're talking about arsenic. We're talking about PFAS. We're talking about persistent chlorinated compounds. And we're seeing, similar types of associations with all of those. Can any of you speak to potential mechanisms that we would expect to be working across all of these? Are we looking at the same mechanism? Are we looking at a confluence of mechanisms that are maybe chemical or chemical class specific but have the same outcome? Any speculations or thoughts on that?
Well, I would want to say that I think that you need to consider the co-exposures that are happening between the infectious agent, whatever the pathogen is, and how the immune system is seeing that in the context of things like the various exposures that are happening, as well as the different genetic and other susceptibility factor background. So all of those things need to be taken into account as we're considering the mechanisms of interaction. We've always thought of mercury as not on its own triggering this, but just sort of lowering that speed bump of activation moving towards some clinically defined disease. Well, if it's very possible that there are multiple pathways to get at lowering that speed hump, and that the same could absolutely be true for many different environmental exposures, modifying the immune response in similar ways that then when that co-exposure happens with the environmental trigger or the infectious disease, that you'll see a similar mechanism of action. The problem comes in that each of these different environmental factors can interact with the immune system. We can track it in very specific ways, and then we don't know enough about all of the ways that the immune system is seeing things and responding to its very different environments in the context of that gene environment interaction thing that we've been talking about, and the microbiome. Like the problem gets bigger and bigger and bigger, and the pathways to activate that immune response or suppress it get bigger and bigger and more complex. So there probably are some underlying commonalities, but trying to define those is a moving target, I think, at this point.
Yeah, and I'll just add that if we're thinking about the microbiome, that some of those pathways of influence can be similar. So you can have efflux pumps that work on multiple chemicals. You can have metal resistance genes that can be activated by various different kinds of metal exposures. But then there are others that are more specific. And obviously, when we're working within a system like the microbiome, the organisms that you have to start with and how they interact with each other are going to come into play. And so that can be niche specific. So we might be talking about something different in the gut microbiome than in maybe the upper respiratory microbiome, than in different environmental media. So just something to consider as we move forward.
Alternate to the left here.
Yes, Carlos Santos Burgoa from the American Institute School of Public Health at GW. Thank you very much. Very interesting reviews, very interesting presentations. I have a very concrete question, a challenging question, building on Molly's commentary. What are the potential implications for public health surveillance of what we know now? Can we do something about it now, or what we need to really make an impact on public health surveillance that we need?
Excellent question. Research translation is always the hard part, right? Some of this, I think, yes, there's absolutely, I'm going to take it to public health action first and then surveillance. With arsenic, there's plenty of evidence showing that it causes human health harm. So now it's a matter of policy catching up with the science. At this point in time, at least in the United States, I think the states hold the line. I'm going to give Margaret Karagas groups huge props. I don't know if any of you saw it, but they're working to pass legislation in New Hampshire to lower the drinking water standard from 10 to 50. So they're going to sidestep some of the EPA regulations. So I think we have opportunities at state levels to make some proactive public health policy around environmental pollution that perhaps is stagnated at the federal level. With regards to public health surveillance systems to try to look at these interactions, I think it's perhaps part of our job as scientists to pick up some of those service mantles that perhaps we set to the side and join these committees and these scientific advisory panels that are involved with setting the research agendas for these big federal programs. So I think that is within our purview, that we could get involved with the NHANES advisory boards and things like that to try to help them evolve some of their assays and some of the data collection that we are doing or we have funding to do in such a way that we can look at these interactions in a more detailed fashion.
Yeah, and if I could add that we are missing the opportunity to integrate veterinary surveillance into human health surveillance. It is an extraordinary missed opportunity for several reasons. The first is, I think as we've shown today, there's a lot of integration of exposure, and animals are part of the pathway of exposure. And that gives us the opportunity to tap into maybe aspects of the retail meat chain or various other ways in which we're exposed to animals. But the other really important concept, and I'm going to give a nod here to Dr. Peter Rabinowitz in Washington for his Canary Project. It is a remarkable opportunity to use the potentially shorter lifespans and accelerated development of disease in animals as a sentinel for human exposure and disease. And so we think about how we share our homes. 70% of us have pets. And that means that we now potentially could be using extremely large data sets that are now electronic for the most part on the veterinary clinical side. And if we could integrate exposure assessment, right, if we could measure the exposure in a way that would provide us the opportunity to get an early window into the development of emergent problems through these veterinary surveillance networks that need a lot of work, in order for them to be useful, then we might be able to understand our human health outcomes better.
Great. Laura?
Yeah, thank you for 3 really fabulous talks. They're just fascinating. From a public education standpoint, I'm just wondering, I thought the global map of arsenic was really helpful in understanding just the distribution of it. And I'm wondering, are those maps available for these other toxins and heavy metals? And do we know what fraction of these heavy metals are naturally occurring versus from industrial processes in an era where we're lifting regulations, allowing more pollution? I think the public should really know what this actually means on potentially on their health, the health of their unborn children, their children, getting that kind of information. Maybe we need to team up with the geologists really to get more of a fine-tuned map, if you will, of where these are. And also, you stole my thunder because I was going to talk about the Canary Project and how it would be really helpful to use companion animals as sentinels for just this kind of measurement, since they do have the shorter lifespans. And we really should figure out how to get them to be part of the Banfield hospitals, for example, have a huge database and could potentially be important partners in this kind of surveillance. So thank you.
Yeah, just to build on that, with one small additional point, I think one of the barriers we need to overcome is how we use those data in a risk assessment framework, because we are well established to look at animal models, maybe even in vitro models and other alternatives as evidence to make decisions. And we have a framework in which we use human epi data, but we really have no basis for the use of these animal data in veterinary surveillance systems for decision making. But for the metals, I turn to my colleagues.
So there are similar maps available for mercury, usually at the state level for monitoring contaminated fish, but you can put them together at the national and sometimes international level. And what's interesting, one thing that Molly didn't touch on, and I know sort of more intimately because I'm on the Eastern Shore where there are a gazillion chickens and chicken farms. A while ago, I was involved partially in a study to look at the impacts of taking the chicken waste from the farms and using it agriculturally as fertilizer during the time when arsenic-containing compounds were being used in those houses as growth promoters, I think, right? Mm-hmm. And so if we looked at, in these rural communities that are mostly on well water, could we track elevated arsenic levels in the drinking water, not just from naturally occurring what's in the rock, so the geologist could help us there, but also from proximity to application of those waste products as fertilizers on those agricultural fields. And in fact, it seemed like that was the trend. Those data haven't yet been published, but it's something to definitely consider. The intersection between the agricultural animal use of these different all kinds of different compounds as well as industrial uses and how that would impact our food chain.
Thank you. Can we go to John?
John Balbus with NIEHS, so I'm not going to ask a short or concrete question, and I hope I can actually make this intelligible. I'm struggling trying to put together the morning and the afternoon. The morning specifically talking about interactions between bacteria and viruses, both out, in the environment and within our own microbiome. And the results that we've seen this afternoon, where the strongest, most consistent evidence was about a metal exposure and levels of circulating antibodies. And also trying to assimilate that with the fact that we have a primary or an innate immune response and then a secondary immune response. And usually with most things, we're getting exposed through a mucosal surface, and yet we're vaccinating, not through a mucosal surface. For varicella, for tetanus, for diphtheria, for many things. And I guess my question is, if I can articulate a question, it would be, given the complexity, given that a lot of the bacterial morbidity, mortality is superimposed on top of viral infections, given that we tend to treat bacteria with antibiotics, which mess up our microbiota and the interactions with viruses, my question is, should we be really looking, I know exposure is always difficult, but we should be looking at different ways of functional assessment of the immune system other than circulating humoral antibodies. Is that really where we should be focusing? That's a model, as a physician, that's what we based, assessment of vaccines on 50 years ago, right? Is that 2019 science to try to answer the question of what is going on with these metal exposures, their interaction with the inflammasome, which is innate immunity, versus the more sophisticated secondary immunity? Is that a reasonable question?
Actually, it's a great question, because it's always, every choice has strengths and limitations, right? And so on a population health level, we're always struggling with between person and within person variability. And we need to reduce that as much as possible. And so that does start to limit what we can really look at a population level. And that is where I think the field settled on vaccine-related antibodies, because it is such a standardized dose. So it really kind of addresses what normally is a huge criticism of epidemiology. So I think there's value there. And then there's also value in the clinical relevance of it. That being said, we haven't made the connection between pollution of PFAS, arsenic, mercury. I would think PAH has actually fallen into that too, and there's a few others that are on the short list, and actual diphtheria yet. I would love to get that funded. And it would be hard to do, because you'd really have to get into, you could probably really only do it through a case control study, and you'd have to be in the midst of an outbreak. That being said, I think it could be done, and it would help to tie that package up in a bow. With regards to your question, is that the only thing that we can look at? No. I think Birgit's 4 compartments, 4 types of exposures is a great way to start thinking about what could be environmentally mediated immune diseases, which I think is a brand new field, to be honest. Who would have thought a metal and eczema, together? And actually even metals and hepatitis is a hard sell. If you still look at all the risk factors for what's hepatitis, it's blood transfusions, men-on-men sex, and IV drug use, like an environmental maybe sometimes you see aflatoxin, maybe. So I think there's still a lot of work there, and then I'll leave it to the toxicologist to talk about maybe 21st or 22nd century outcomes.
I think we're running out of time here. The clock keeps changing, but it's going up now. Okay, so I think we're supposed to stop.
Good to go to another question then.
This really awesome conversation that hopefully will continue on throughout the workshop, and hopefully some of you who haven't been able to ask your questions can ask them at other sessions, or it will come up in other discussions. But I want to thank you all so much, and Birgit from Norway, for this wonderful, inspiring, and illuminating session. Thank you.